Hi, my name is Rebecka and I'm working in the northern part of Israel in a hospital called Nahariya Hospital, which is also a medical center. And I'm going to present a case that we had recently. Now the patient was a man 40 years old with no previous medical history. He presented to the emergency room with a skin rash on his chest and on his neck regions. Now the patient also had shoulder pain, wrist pain, and general arthralgia. And he also suffered from mild dyspnea and had a dry cough. And there was also noted B symptoms like night sweats and fevers. Now, we did a lab workup on him, and he had, I want to point out that he had increased CPK and it's increased CRP. His anti-nuclear antibodies were also increased, and so on. Now, because of his dyspnea and difficulty breathing and his mild cough, so of course we did a chest X-ray, and here you can see that there are some interstitial lung changes with the predominance on the lung basis with some consolidations. And so we continued, of course, with a chest CT. And here, what do we see? So we see some ground glass opacities and some consolidations that are quite patchy, and interstitial lung changes with the predominance on the base of the lungs. And yes, and so because of the B symptoms, so the department he was admitted to decided to do an abdominal CT. And I choose here to show you the pelvic region because he also complained about a very weakness around the proximal thigh muscles and proximal muscle weakness in general, and he had difficulties to sit down and to rise from a chair. So we decided to do another type of investigation. What do you think we did? So we did an MRI, and here you can see that this is a T1 weighted image. Can you see any pathological features here? I would say no. I would say that it looks quite normal, like with nothing to say about this one. So we continue, and we choose to do some fluid sensitive images. This is all STIR images, and here you can see the pathology quite clearly, I think. So what do we see here? Can anybody who wants to try? So I'll tell you that what we do see here is an increased signal intensity at the, at the proximal thigh muscles and the muscles around the hip, the pelvic bones. So we continue with the contrast enhanced MRI, and we see that in the same parts as we could see an increased signal intensity on the STIR images, we also see some enhancement Now we are getting closer to, or we can already say that we have an answer. This is a typical appearance of muscle edema. Now, the definition of muscle edema is an increased signal intensity on T2 weighted images with an otherwise normal anatomic architecture. And now, do you have a clue what can be our diagnosis, or at least our differential diagnosis here? So it could or be infectious myositis, necrotizing fasciitis, or an autoimmune disease myositis like polymyositis or dermatomyositis, right? So what would you think? Yes. So we're getting closer, or we are at the right direction. So autoimmune myositis fits our picture quite well. And now back to muscle edema a bit. Now muscle edema is something that it's a quite common pattern on MR and images. And in order to provide us the right diagnosis, the history will give us a very good clue. Now, trauma is the most common cause of muscle edema. But there are, of course, many other reasons. I told you about trauma. There is the entity of myositis, which would be infectious, necrotizing fasciitis, autoimmune mediated myositis. The reason of edema can be secondary to radiation therapy, diabetic myonecrosis, or drug-induced myositis and rhabdomyonecrosis. Now, why wouldn't our picture fit into infectious myositis? Because, first of all, think about the clinical history. And secondly, our case was very symmetrical. And usually, an infectious myositis leads to abscess formations. But we have to keep in mind that sometimes the viral infections viral infections does not cause abscess formation, and sometimes they can also be symmetrical. So it's very important to keep that in mind. Necrotizing fasciitis, as we all know, it's a very, very emergent and toxic situation for the patient. There is a spread across the facial plane within the subcutaneous tissues, and the diagnosis should be made immediately with CT, and there is no time to wait for an MRI here. And inflammatory myopathies defines a group of muscle disease causing inflammation of skeletal muscles, and often adjacent fascia, and now there can be pulmonary involvement, and there is usually elevated CPK, which is marker for the muscle distraction. Now, they are thought to be autoimmune disorders, and they include two separate entities. Dermatomyositis and polymyositis. So what's the difference? The difference would be that polymyositis affects the skeletal muscle only, and dermatomyositis, as the name tells us, also affects the skin. Now, dermatomyositis, idiopathic, it is characterized with proximal muscle weakness, It has cutaneous manifestations, it's unknown, and in the later stages it can cause very extensive soft tissue calcifications. Now, those calcifications can cause very, very severe contractures. And mostly in the very early phases, there is no abnormality in the CT, which was shown in our case. And the MRI will show muscle edema, which is symmetrical. Now, in conclusion, we had a triad of pulmonary, dermatological, and musculoskeletal complaints. But because of some MSK features like swollen joints and some lab values corresponding to rheumatic arthritis, this case was concluded as an overlap syndrome between dermatomyositis and rheumatoid arthritis. And that's about it. Thank you.